And so I wanted to just lead off by saying thank you to all of the primary care providers. So many of you who've reached out either with calls or texts or really eloquent and thoughtful messages. And just want to level set to say we are absolutely fully aware of the overwhelming numbers of patients that are coming to your practices right now. They're also coming to the urgent care centers and to the pediatric emergency department. It is a waterfall or a fire hose. And so I just wanted to say that we recognize too that this is a constellation of sort of the most awful perfect storm, that viral illnesses are at a peak like winter. If somebody can mute. That also we do need to do these protocols for COVID testing for kids in order to, be doing a good job from a public health standpoint and keep our community and our kids safe and keep schools open. We also recognize that all of the really smart processes that many of you stood up by investing in PCR testing platforms for point of care testing. Now you're faced with the cartridge shortage and not a clear time date being indicated by Cepheid at least as to when these things will be coming back and when you'll have that capacity again. Couple that with shortages of staff and the fact that I think there's a lot more pressure from families, understandably, to get their kids back into school, to have a more efficient and rapid system of testing so that we don't have kids sitting out for extended periods of time who don't need to be out, and families are feeling really pressured to be back at work. So for all of those things make this really difficult. So we recognize that this is more than a little Band-Aid fix. This is really a surge response that we have to make. And it means we have to modify some of our current workflows, but also stay in line with state guidance and, be true to a smart public health perspective. So I just wanted people to know upfront, we absolutely hear you. You could not have been clearer in explaining to us what this is like. It is untenable. It is non-sustainable. And the last thing anybody wants to have happen is that we burn out the healthcare provider teams that are left standing now at a time when we need our healthcare provider teams the most, and we need to be preparing potentially for COVID vaccine for our younger population in a month or so. So with that, I am going to just turn it over to Mike, Dr. Mendoza, the things that you might want to add, and maybe if you want to answer any questions. And I recognize we don't have a fully fleshed out plan right now, but there is something that will be rolled out this week.
Yep. So thanks, LJ, and thank you all for your hard work, not only the last several months, but for the last 18 months. I feel it. I appreciate your feedback. I've heard the feedback both from our medical community as well as from the school. So I'm getting it also from that side as well. It's clear to me that we need to make some choices. There's no path out of this that's going to minimize all risk. The current path that we're on really puts you all at risk and our ability as a healthcare system to care for our sick patients. But if we go too far in the other direction, then we risk what might happen in the public health sphere with COVID and future variants and so forth. So one thing that is relatively not negotiable is that we need to have a NAT or PCR test to return kids to school. And that's based on our New York State guidelines because we're still in a high risk transmission area. And we're not anywhere close to getting out of that high risk. Most counties in the state are not even close to getting out of high risk. So we need to have PCR tests to return kids to school. So the question really is, are we taking too many kids out of school, and or can we get the PCR tests more readily? So one change that I am looking to implement in the next 24 hours is to eliminate the need to have all kids seen by a healthcare provider in person. Obviously we've got to have some guardrails around that. We don't want kids at home, suffering in silence. We don't want parents in a position where they are trying to make medical decisions. But for those kids who have a sneeze or a simple self-limited symptom that are getting sent home because that's what our protocol says, can we get them back to school without having to see you all? Certainly if parents want to, that's a different story. but we don't want to make it so that they have to, even if they don't want to, or even if we think that they don't need to. So that's a change that we're working on. The other change I'm working on is trying to get PCR tests or nuclear tests to the schools so that they can rule in or rule out quickly and get that PCR test to that kid and potentially get them back into school without having to see you all as well. So those are the two main changes. A lot of details we're still working out. We're working with the school districts to figure out what's actually going to be able to be implemented in the next 24 to 48 hours. But that is sort of where we are right now. We are also working on the vaccines, which we can talk about in a little bit, but I wanted to just put that out there first. And was there anything else, LJ, that I'm missing from our talk this morning?
I think the only other thing, Mike, and I mean, this is conversations in progress, but since for schools that, or for practices that don't have the ability to do the nucleic acid testing, we need to have a way to get swabs turned around more efficiently. And so there are meetings that will be happening over the course of today and tomorrow morning with both of the main labs, with URMC and Rochester Regional, to determine if we can have a high prioritization status for PCR tests that are coming from primary care practices or from schools. Because really, you know, we have to have the fastest turnaround time that we realistically can have in order to get decisions made, get contact tracing started, and get kids back in who don't need to be out. That's the only other thing.
Yeah, thanks for adding that. So I don't know how much it will help to prioritize the PCR swabs coming out of your office because you're still going to be seeing them potentially. We'll certainly try to do that just to get the result back to the kids and families more quickly. But the other thing we're working on is having the school nurses do nasal specimen collections that are run in the hospital labs for PCR testing. So that would take them out of your offices and waiting rooms and potentially get them back to school quicker. And so we're talking with the hospital leadership this afternoon to see if we can create that lab capacity at each of the systems. So hopefully that will take the demand out of your offices.
I think the only thing I would just add to everybody is, you know, we see the world from the medical provider perspective. You know, these are all things, I think it's important to be transparent that we're working on this because I think you really need to hear that we hear what's going on and trying to make system level change. But, you know, Dr. Mendoza needs to be able to roll this out in a really effective way where schools are hearing at the same, like what the real changes schools are hearing at the same time as the healthcare system so that we're not fighting each other. And I think all of us know, because we've gotten used to this during the pandemic, it also, with any new guidance that comes out, it takes a little bit before everybody gets on board. So the more that we can make the guidance clear and make sure that the systems are supporting that work and that we, you know, we're not asking people to do something that's not feasible, the better off we'll be. And I think we have shown the ability to pivot so many times for the last 18 months. And right now, I think everybody needs to pivot for kids. We've done, you know, apologies to anybody who cares for adults, but we all have kids. Kids should be a priority, and we really need to get this right. So,
LJ, can you speak to how the decision-making coming out of Monroe County is going to filter into the other Finger Lakes and other districts? How will it be shared with them?
I'm going to actually let Mike speak to that. I'll just say that because the schools reopening task force has been a Finger Lakes task force, that clearly any changes that Monroe County is making, you know, these conversations are happening. Honestly, some of the outlying counties, Mike, right, are already looking at alternative strategies. And so hopefully this, you can never assure complete alignment, but hopefully there will be as close alignment as possible.
Yeah, we're certainly going to try for alignment. But LJ was alluding to some counties have already worked on getting PCR or NAT machines to some school districts. So some schools are already doing this. So it won't be as big a leap, but we're going to try to have alignment as much as we can. But obviously my priority is just to get it straight here in Monroe County. I think we have, because of our population size, it's always been the biggest lift in the region. So, you know, we're going to start with Monroe County.
The chat is remarkably silent. And you all are too. So I think we've got a few more minutes. Does anybody have any, you know, comments, feedback you want to throw into the chat? You're living this. we think that this is the best approach, the best pivot we can make right now. But if people have suggestions, thoughts, or even if you feel like you want to give a thumbs up, feel free.
One is out of thumbs.
Well, I'm certainly
Appreciate
available
your
for any other
time.
feedback.
Nick, I think Nick Apostolo.
I don't know if this team has sent it to you, Dr. Mendoza, but your leadership has been appreciated here in Livingston and Steuben County as well. So it's just thank you for taking the time to give us the heads up
Yep.
here.
My pleasure.
Okay, so the chat just got active. So I'm going to try to parse out a few. Mike, if you need to drop off, we will keep going. Is there anything else that you want to say to the group, or do you want to entertain
No,
questions with us?
simply, yeah, you all are welcome to reach out to me directly, please. Michael Mendoza at monroecounty.gov or U of R Global. I'm happy to hear your feedback, but thanks again for your time.
Thanks, Mike. Appreciate you joining us.
Yep.
Okay, so we've got, there's a question about rapid tests from Genesis Pediatrics, but I'm not seeing where the question is. Do you want to, oh, there we go. Schools on the west side are saying rapid test is okay. Anybody want to unmute and ask that question? Because I'm not sure what the question is. Is it that we need clarification about rapid tests? Sorry, go ahead.
Hi, LJ.
Hey.
So the question is, they're saying a quote rapid test is okay, but they're not saying what rapid test they're referring to or where people are getting this test from.
Yep.
So that's very confusing to us because we don't want to give people the wrong information.
Yep. I think this became even clearer to me today just because of the state guidance. Some of what is acceptable depends on your community rate of transmission. So if you look at the state guidance, if you have very low transmission rates, there is a caveat in the guidance that a rapid antigen test could even be acceptable for a symptomatic patient. But that is not the case when you have high rates, when you're in the high rate of community transmission. And that's where our county is, that's where surrounding counties are. And what Mike was saying at the beginning of this call is we are nowhere close to getting into that lower rate. So everybody, really, to get back into school, what's required is a nucleic acid amplification test. That includes PCR, that also includes some other forms of NAT testing, but any kind of antigen test. So like the antigen test that the schools have, that's like a little pregnancy test almost, with a little kit, those don't count. They cannot count. Home testing by families doesn't count. So it has to be, it's sort of still a higher bar around testing, not quite as high a bar as we really feel would be ideal for a community standard, which would be PCR.
60
Okay.
to 110 per day.
So, yeah, and I know we're hearing those ranges of COVID testing, for some of the larger practices in the 100 tests a day range. So I hope that answered your question, Liz, and we will be very clear in any communication that goes back to the schools about what exactly is needed and clarify that with the schools. Danielle, did you get your question answered about the amount of testing that's happening? Looks like yes.
Yeah.
Okay, perfect. That's great. Good communicating in the chat. And then I saw another question in there. I'm trying to find it again. Miriam Bauer from Elmwood, but there was another question there too. Did I see?
Yeah, there's a question.
At this time, patients still need a provider visit to return to school. So yes, at this moment of time, until something changes in a written format that will be communicated to pediatricians or primary care providers, healthcare providers, and to schools, that is what the guidance is we have been following. And I am anticipating some revision to that will occur within the next 12 to 24 hours. One of the things that's really important to convey is this doesn't mean that kids who might have COVID don't need to be seen. It doesn't mean that kids who are sick don't need to be seen. I think what they're trying to do is take away these very short-lived symptoms. The child who sneezed once in the classroom and then got sent home and now is waiting or knocking down the door to come to your practice and their symptoms have resolved. The transient abdominal pain, the transient headache, all the things that you all have talked about that's creating, an excessive burden. One would hope that the kids who continue to have, that if kids continue to have symptoms or a worsening, they would land and show up in your practices. But if you can't see them because you're doing a gazillion nasal swabs for kids who probably don't have COVID, but none of us can tell, there's no symptom priority list. We have to do something. We may miss a couple cases of COVID initially, but if we speeded up the turnaround time, honestly, on the testing that we're doing and the resulting of that, and we're able to enhance our contact tracing a little bit and made sure that the healthcare systems can actually see the patients who need to be seen, the ones with behavioral health needs right now, and the ones with acute care needs and preventive care needs, we'll be doing a better service to our community. Joan Flender has said the state guidance says we can use Bionex if NAT tests are not easily available. So Joan, I will tell you that the Bionex, I'm going to just ask you to clarify, is the Bionex an antigen test?
I think Binax now is the Abbott antigen test that has
The one
been-
that the schools have,
Yes.
right?
Yep.
Okay. So Binax, okay. I was reading and confused by what I was reading there. So the county health department had gone back to the state stating the concerns around this, and we're told that we still at this time needed to try to lift the NAT testing. I think they're circling back again. That's all I can say right now because that's really not in my purview. But I hear what you're saying. The issue is we can get PCR testing done. URMC Labs and RRH have said that they have the capacity to be able to do this, but we have to be able to do it quickly. And then we have to figure out a courier system to do it. More to come on that. I hear exactly what your question is. And we were trying to push on it today, but we didn't get too far.
There's a question up higher in the chat, LJ.
Yep.
Regarding, did you see that one regarding if nasal swabs are allowed in the school testing for symptomatic patients? Would we be matching that in the office? We're still doing NP or nasal turbinate swabs.
So when we say nasal swabs in the school, the idea would be that you have to get the swab in to feel a little resistance. You have to get it in the nasal turbinate region, but not NP. And I think that the practices should be doing the same at this point because I hear where you all are and what this is like in your offices. And you can't, we had said, try to do your best. It's really hard to get those NP swabs for kids who've already had them done. And so my sense is from talking with Brenda Tassini and others that if you can get the nasal turbinate region, that is adequate. So I don't think there's a need to, we could have similar expectations on either side because not every kid's going to be coming into their school. Some of these kids are coming into your office sick. They're not going into school, but plenty of them are going to school sick. Yeah. So I don't know if AHP has access to media to get education to help with the extreme frustration and anger that is out there, but I think we could mirror and help support what comes out from the county. And we have asked for very clear information for families at this point. And I would say that the AHP team is really looking for ways to be able to support your practices. So I'm seeing some of them on the call right now. We've certainly done other forms of messaging in like the pharmacy pearls, we could look at something hopefully that you could use for your practices. And I'll ask the HP team to think about that. But whatever we would put out would have to follow whatever the guidance is that's coming from the counties and make sure that we're mirroring that. It is, we know that you have people screaming at your staff and that is just not okay. It's not okay. I missed another question in the chat. Help me, Renee.
Dr. Abels, for those kids
Oh,
who
I was.
you've seen.
So the notion, so I don't want to speak to what this is going to look like because I think there's going to be a couple of modifications that happen before Mike puts out this guidance. What I anticipate is going to happen is he's going to try to relieve the need for patients with very short-lived symptoms to have to be seen by a healthcare provider. And I don't know what that timeframe is going to be, if it's 24 hours or what. That's the idea of trying to get the COVID test done in school and have the child be out and return with just the COVID test without the need for a healthcare provider determination. For kids who have longer lasting symptoms, I'm not sure what his guidance is going to be on that front and what the team is going to decide. Because at the same time, you all exist for, I mean, there are kids that need to be seen, right? If they have symptoms that are ongoing and will need some form of assessment. The language may turn out to be something like to consult with their healthcare provider as opposed to requiring the healthcare provider assessment. The other thing I will say is we do have a lot of kids out there who don't have a primary care provider, who don't have insurance. And so we are creating an inequity in this space too, for those kids who are just sitting at home without access to someone to be able to see. And our urgent care centers, we're filling that need, and they are like you are seeing 2 to 3 times the number of patients that they normally see. So honestly, we feel that we have to have a different system. What we created worked last year. It's not working now. And that may include if we have difficulties standing up PCR or NAT testing fully, to Joan's point, that may include having to honor antigen testing, but we are not there yet. Chad, I think I'm going to turn over to you unless I just give people a moment.
One thing, LJ, do you want to talk about the potential next week for an additional
yeah.
call?
Yeah, so internally within AHP's team, we have talked about that, like I said before, just like at the beginning of the pandemic, we felt like our role working with all of our practices and our practitioners was to think about how we could support your work. Like, what did you need to be able to do the work of caring for patients? And we feel like we're right back there again right now. I feel like the community level public health protocols, that's not in AHP's wheelhouse. I mean, we definitely brought to Dr. Mendoza's attention and we're bringing to the hospital's attention what your concerns are and what your situation is. I think that is our role, and we're trying to help in that solution, but we don't get to own that piece. But I think if these workflows change, we would, or when these workflows change this week, we'd like to meet with you all again next week. And what we wondered about doing was just a second COVID call, a 12:15 call on Thursday of next week. So the normal one would be Wednesday. Chad will give his State of the Union, and we'll go through, any changes, et cetera. But then on Thursday, for those of you who could join, or if you could have one representative from your practice even join, we'd really like to hear from the independent practices, family medicine, pediatric, and adult practices. What are the other pain points right now? What do you need? Because we would like to be able to be as responsive as possible. We are deliberately not reaching out to you all about initiatives and other things right now because that is not the time. So if you can, if that seems reasonable to folks, we'll send out an invite. And for those who can join us, it will be an interprofessional team and the leaders from AHP listening in on that, asking some questions, and then coming up with some what supportive responses and help we can. So any questions? Anybody want to unmute? Send an email. Like, seriously, your feedback right now is actually really important because your silence makes me think we're missing something even more. And I'd rather hear like irritation or you're missing the boat or, okay, this may help. Like, I've talked to a lot of you, but I certainly haven't talked to all of you.
Either slow typing or still silent.
Well, it also could be that people are multitasking right now and they're all seeing patients and on the call. That's a very real thing.
Yeah, that's the thing.
Okay, folks,
All right,
I'll watch for emails from you. Let us know if we're on the right track.
perfect. All right, so brief updates on my standpoint today. And obviously we're happy to talk more if there are other questions that come up, obviously bigger issues to fry. So while we're dealing with all of this, I think there's kind of two things going on, and you guys know this better than me. We're actually seeing a decrease in that doubling rate, which is becoming more and more how we're talking about this, how fast are cases rising across the community. Almost in every county in the Finger Lakes region, we talked about this last week. It's even more so true this week, that the doubling rate is diminishing fairly quickly. So that's good, even though we're still seeing a reasonably high preponderance of cases. The case rate is still not what it was as far as increase, daily increase, even compared to a couple weeks ago. That being said, what we are seeing is a huge surge in RSV cases across the region. And unfortunately, because the presentation looks very similar, it's making all of this testing an issue more complicated, and especially as the kids are coming together more. In particular, it's spreading, and it's spreading even the adult population. So, you know, that kind of cold and flu season that we were somewhat spared from last season is kind of rearing its head this season, unfortunately, which is making all of this that much more complicated. So, you know, along with that, there's continues to be a lot of discussion about variants. We still have not seen any other significant entry of variants, even though Mu and Lambda and some of these other variants are getting some headlines. It's still not by any means common or even seen even occasionally here. We are still very much Delta if it's COVID, and then seeing RSV as a predominance. We have seen a couple of cases of flu, but in the range of what the lab would report would be false positive range because of the relative infrequency. I think as of end of last week, we had one positive flu A and flu B. So we're starting to see those potential sentinel cases, but it also could be just false positives based on the number of people that are getting tested for viral syndromes in general. So that's where we stand currently. Other issues that are active that are of importance. So the religious exemption restraining order, we talked about that before. That has taken a little bit of a new path. So the 2nd District Appellate Court has now taken this up. It's within their purview to do so. But there are actually hearings going on today that could supersede the Utica Court that has the follow-up hearing on the restraining order on October 12th. So what does all that mean? So the governor and the state feel very strongly that they are likely to get this restraining order overturned or lifted. The 2nd District Appellate Court could do that as early as today, and their order would countermand the Utica Court. So if that were to happen, those healthcare employees that are in hospital or congregate care settings who are continuing to be able to work under a religious exemption may lose that exemption accommodation. So then obviously we'd have to discuss what does that mean as far as timeline of implementation. All of that would be under the purview of the court and or state. And we don't really have good insight, although I can tell you there has been some discussion that there would likely be a grace period allowed if that religious exemption is overturned. So more to come on that, because across the state, we saw about that either resigned or lost their position because of non-compliance with the vaccine mandate and because of lack of a medical or religious exemption. That number could grow, and in some places could be 2 to 3-fold that if that were to occur. So there's everybody is kind of watching the judicial system over the next couple of days to see what happens with that. At the same time, and many of the private practices, I think, are becoming aware of this as well. There is a increasing competition for these traveler agencies to recruit, particularly nursing, but even med lab tech, LPN, patient care techs, as well into the traveler program. So folks are getting exorbitantly high rates, especially if they're willing to travel out of state. And we've heard from states as nearby as Virginia. If you go back 6 months ago, certainly a year ago, nurses through a traveler program were running about $50, maybe $60 an hour. New Jersey right now is commonly seeing figures of about $260 to $270 an hour for nursing staff. So we are seeing, especially Florida, California, and Texas are starting to gobble nursing staff up at extraordinarily high rates. And there was one hospital in Southern Florida that I heard yesterday, I think it was Steve Goldstein that shared, that it's a 600 bed hospital, 270 of the beds were filled with COVID patients. So that is a much higher instance than what we're certainly seeing here. But that hospital was spending $16 million a month on traveler nurses to staff the hospital. So you can see kind of the level that this is kind of rising to. So that is going to continue to be an issue. There has been a lot of discussion at the governor's office level here in New York about whether there would be some type of restraint on folks' ability to leave and practice within a certain distance of their original employer, or even able to leave and practice within New York State. But none of that has come down officially at this moment. The other thing that we are running into, and it's a similar story to what we're talking about with the kids, is in our pre-op and asymptomatic testing group. So the numbers of tests, or the number of pre-ops, are going down overall because elective cases are getting canceled across the region. However, folks are kind of using those forays to get testing done. So one of the conversations is for the true pre-op testing, to try to conserve the nursing staff, but also to conserve the PCR test for where it's needed most, given that the asymptomatic testing still seldom comes back positive. Can we convert the pre-op testing to an antigen-based test rather than a PCR-based test? So that discussion is being held tomorrow. So we'll let you know how that goes, but that may decrease, especially if we're looking at shortages within hospitals of nursing staff and the like, but also, possibly improve turnaround times on PCR testing if there's less volume demand on those systems. Other than that, I think we're pretty much stable where we were. I think in this region, from a hospital setting, what we're generally seeing is a reduction in bed availability in almost all of the hospitals across the region at the moment. I know that has caused some problems. Urgent cares are then backing up. Emergency departments are backing up. That's creating more pressure on the practices because patients aren't able to get in and be seen. And not just for COVID respiratory issues, but other issues that they're presenting with. We're seeing certainly longer wait times in emergency departments and urgent cares. And there continues to be discussions of certainly hospital system-based urgent cares from really all the systems in the area that run urgent cares. Would they have to close or curtail services at some of the urgent cares to recapture nursing staff? Same way with surgeries and elective procedures. We're seeing about a 15% reduction on average, if not more in some areas, of elective procedures currently. And certainly depending on what happens with these mandates, that may get curtailed further. So for folks who are looking for screening tests and that kind of thing, we're not quite to the level that we were back in March, April of last year, but we could be heading that direction very quickly. The final piece I would say is phlebotomy. So for all of your practices, I think across the region, we have seen a fairly significant reduction in phlebotomy staffing. These are folks who oftentimes are in the wage market that they could leave healthcare and potentially get similar wage levels in non-healthcare settings. So we have seen a reduction in availability of phlebotomists. This is both affecting inpatient, but even more so ambulatory blood draw stations. So we have heard that the wait times at some of these phlebotomy stations are growing. And in some cases, some of the draw stations may close. So certainly for routine blood testing and the like, we may see some reduction in availability of services there as well. So just something that we'll continue to watch and report up to you guys as we learn more and as we kind of see the ripple effects. We're going to continue to see these ripple effects for a while, almost regardless of what happens with mandates, both at the state and federal level. The staffing, we have clearly seen some exodus of healthcare staffing across the spectrum, and we're not going to rapidly retrain that in 2.5. Yep, there you go. Like 2 hours a couple days ago. So that's unfortunately could become much more the norm as we go forward. So I think across the country, but certainly locally, we are going to see some diminution in staffing levels. That is going to rise to somewhat unprecedented levels that we talked about could be coming in the next 5 to 10 years with retirements and aging of the workforce, but has been largely accelerated by people leaving healthcare or exiting because of the mandate. So I do think there's going to have to be some restructuring across the healthcare delivery spectrum. And that's certainly something that, I'm not going to say that HP has all the answers, but certainly will be a discussion forum that I think, as LJ's talking about hosting next week, of how we handle in the clinical practice realm, how do we handle healthcare delivery going forward, because there's going to be less people involved for sure, I think, as we look to the future. So lots of stressful days ahead for sure. I know a lot of folks are already bearing this currently, and everyone's kind of looking for that bright, shiny light. I think the only thing that remains the hope is if we look internationally at the countries that came before us with the Delta surges, those surges did diminish very quickly. So it is possible that if we follow an India or UK pattern, that we could be seeing, with all this decrease in doubling rate at such a precipitous rate, we could certainly be seeing a significant downslide in the presence of COVID. But it's just much too early to tell that at this point, and certainly with the RSV and flu season kind of competing, it makes it that much more complicated in the short term, for sure. So I think that's all the updates that I had. We've still got a few more minutes, so if folks have other concerns or issues, we can open it up. Renee, I saw you possibly have something.
I would just mention that we'll have details in the in today's update email about the change in ordering process for monoclonal antibody therapeutics. As you recall, a couple of weeks ago, the feds changed it from a process by which providers could order directly, that now the state will be doling out an allocation, and the process to request an allocation from the state. We'll be sharing the details of what that process is in the update email. So I just wanted to preview that. That's it for me, Chad. And thanks to the pharmacy team for digging that one up and sharing it with us.
And I will say this has actually been an interesting turn of events, but even in the hospital setting, we are now hearing of patients who the two most readily available monoclonal antibody, the B one that I could always forget the generic. I'm sure one of the pharmacy teams will chime in very rapidly with this. So patients will accept Regeneron, but they will not accept the alternative. And in some cases, the Regeneron is not as readily available. And so we have patients, even in ICU settings, who will refuse unless they can get Regeneron because of the political. There you go. Why would I not remember? Such on the tip of the tongue. That has, the misinformation and distrust is not just in the vaccine arena, but is even into the therapeutic arena now, that it's causing some issues that, just unheard of, obviously, in healthcare previously. It's a whole lot better than I was. I still can't pronounce it when you put it on the screen. All right. So with that, anything else anybody would like to see us working on and needs us to get more information about? All right, I know everybody's stressed and has other things to do, so we will give you the 4 minutes of your life back. And we will be in touch with follow-ups on all of this as we learn more. And certainly keep the questions coming and we will try to address them as rapidly as we can. So thank you, everybody, and best of luck in the days ahead. Talk to you soon.
Thank you.
Bye.